This is lecture 17. The previous one was about the determinants of force production in skeletal muscle. And in this one, we'll start looking at injuries, sort of dipping our toes in that pool. We'll submerge ourselves completely in the injury pool soon. But for now, it's time for a little bit of toe dipping. And we'll talk about these three topics: joint compression, particularly in the back and the spine, but joint compression, neural rewiring, and some therapeutic solutions, looking at that a little bit. So, as you already know, skeletal muscles cross joints. And when one of those muscles shortens through sliding filament theory, it compresses the joint that it crosses. It just rams the articulating bones together. And you can see this in the bicep diagram. The humerus and radius are pulled together when the bicep shortens. And you can feel it in your own elbow if you flex your biceps and triceps simultaneously. To an extent, you can watch it happen in your arm as you flex. And you can also see this in the legs and in the spinal extensor muscles, which cross vertebral joints. Each intervertebral disc is a joint, and the spinal extensor muscles cross a lot of those joints. So when those muscles flex, it compresses the discs. Looking at the spine, you can see the vertebrae. Above and below each vertebra is an intervertebral disc. Again, that's a joint. It moves. And remember from one of the previous lectures where I talked about rigid ski boots and knee braces and how loads get transmitted to adjacent joints when you're wearing those things. If you were to fuse a couple of vertebrae together, you would experience the same phenomenon because each joint in your spine contributes a relatively small amount of motion. And when you have a bunch of them contributing, you get a good amount of gross movement, total movement. But if you were to restrict the motion in one of those vertebral joints, the other adjacent joints would have to pick up the tab. And that's likely going to advance the degeneration of those discs. But a much more common cause of degeneration is compression. All you have to do is flex the muscles that cross those joints, and it'll smush the vertebrae together. Um, and this is a first-class lever system. The fulcrum is the disc. Um, Behind the fulcrum on the back side of the vertebrae, that's where your spinal extensors are. And then the load is in front of the vertebrae. Probably a fair amount in front, especially if you're carrying something. So this is a class one lever system. And the muscles have a large mechanical disadvantage, which means that muscles are producing more force internally than externally. Often, I mean, this can exceed a factor of 10. So it's a pretty big mechanical disadvantage. And so your discs get compressed a lot. They get compressed a lot. And that's on top of the compression that it's already experiencing by just having a bunch of body weight stacked above it. So when you start exercising, you're going to exacerbate this compression, which means that form matters while you're exercising. Form matters. In this study, what they were looking at is the compressive load at L3, L4. And it was 6 to 10 times the subject's body weight. And the amount of trunk flexion seems to be what affects spinal compression the most. So when you're squatting, the compressive forces are minimized. They're not eliminated. I just mean they're not exacerbated. They're minimized uh, when the back is either flat or in a slightly lordotic curve. So I have three herniated discs in my own back. L3, L4, L4, L5, L5S1. And so I'm really cautious with this stuff. I can't load my back without consequences. So my leg exercises have a cautious posture. And I used years ago, I would go to Bond Fitness Center and in what used to be called the rubber room, there's this row zone where it looks like maybe people get carried away. And I would do ball squats there. And as I would do my ball squats, right across from that, people are doing their own squats, right? And actually, like right next to me, people were always jump roping. They came up and like literally hit me with a jump. Like I caught one of the jump ropes once, and the person was confused why like the jump rope stopped spinning, and then like he turned around and he was still confused when I was glaring at him because he was hitting me with his jump rope. And that was, I think, the last time I ever went to Bond Fitness Center. I was like, I can't be in a place where nobody knows what they're doing. But while I was doing my ball squats, I would look over at the people doing normal squat. That sounds creepy, but I was watching their spines. And after like a couple of years of watching people's spines, I never once saw a single person perform a single repetition in a safe on the discs way. Usually it's like ass to the grass stuff, which like not all rhymes contain wisdom. I think we all know that. And just like so, watch people when they're squatting. When you're at the gym, whatever gym it is, even if you feel creepy doing it, just watch. You'll see them tuck their sacrum in, like at the bottom. It looks like a bee sting, where they have this little, I think people call it like a butt tuck or something like that. And you know what that does to the compressive forces on the disc. And the discs aren't entirely avascular, the nucleus pulposus is, the sort of gelatinous center is. Uh, but the annulus fibrosus, the outside, that has a little bit of vascularization, but they're not well perfused and they're terrible healers. Discs are terrible healers. So you can liken them to tires, to like car tires. And once the tread is worn out, that's it for them. So you have to be careful with your driving so that you can get more mileage out of them. Intervertebral discs were perfectly fine when life expectancy was 30 or 40, right? But life goes on like for a while these days. And bad squatting, even if your cliche about it rhymes, is not going to contribute to your net happiness as a human being. I promise that much. So that's spinal compression, right? And depending on how you're bending directions and how you're doing it, that will influence the signature of degradation in your discs. Just like how and where you drive affects the pattern of erosion in a tire's tread, the same phenomenon applies to your discs. And you know where the afferent information arrives, right? In the dorsal root, posterior laterally. And then you know where the efferent information, the motor information, where that exits. The anterior lateral side, ventrolaterally. And so if we're getting herniations in those spots, we're having nerve problems, right? And that can manifest in a lot of different ways. Looking at how we can reduce spinal compression during exercise, intra-abdominal pressure, that's one way. The Valsalva maneuver is a way of increasing that, of increasing intra-abdominal pressure. And this is the Valsalva maneuver. This is you trying to blow out air, but you can't, right? You have a closed glottis, or you can just like plug up all your holes and try to breathe out. If you're not exercising and you do the Valsalva maneuver, you'll increase disc pressure from very little to a tiny bit more. But if you're doing some strenuous exercise and in that moment you do the Valsalva maneuver, that increases intra-abdominal pressure and can decrease the load on the discs a little bit, right? It's not enough to get like passionate about it, but you can see a little bit of a decrease. And in the article here, in the quotation from the article, they're talking about kilopascals. One of those is 7.5 millimeters of mercury. Now, that doesn't matter. That's just for a point of reference. You don't need to know values of anything, just concepts. That's all you need to know. These are the graphs from the article. There are four different exercises: the lateral bend, flexion, extension, and axial rotation. And the Valsalva maneuver reduces spinal compression slightly, right? In all four motions, higher intra-abdominal pressure associated with less spinal compression. Now looking at weightlifting belts, these work too. Put on a tight belt and breathe in, and the breathing in really helps. You'll see the spinal compression reduced by 10% or so. It depends on who you are. These are mean values, but that's a pretty meaningful mean if you're hoping to, go a few extra miles and save some tread on your discs. And the one thing that you'll see with the belts is a reduction in the muscular contraction that contributes to spinal compression. And anything you can do to dial back some of these contributors, the muscles themselves clenching the discs together, you'll see a reduction in the total spinal load. So now let's look at where compressive forces occur in the back, thoracic versus lumbar. We're ignoring cervical here. You have seven cervical vertebrae, right? The neck ones, seven of them in the neck. In your like ribby area, you have 12, right? Those are your thoracic. And then there are five in your lumbar, say the low back or lumbar spine. Where your ribs attach, that's thoracic, right? Above the ribs, that's cervical. Below the ribs, that's a lumbar. And again, we're just looking at thoracic versus lumbar where the compressive forces are. So start with the middle person. Look at the person in the middle. And looks like a he, I'm assuming, is bending forward at 30 degrees, not even carrying a box. And that gives you the same compressive forces in your lumbar spine as standing up straight, carrying the box. Um, so call those erector spinae, the spinal extensor muscles into the equation, and you get spinal compression. You get compression in the discs. But let's look at the first two pictures. Uh, Carrying the box normally and carrying the box while bending forward. Notice the moment arm of the load, how it differs in the two diagrams. It goes from the thoracic spine, right? That's the fulcrum here, to the external load. It goes to the box. So from the fulcrum to the center of mass of the external load, meaning the spine to the middle of the biohazard box. So that's the moment arm of the load. And when you bend forward, the moment arm of the load in the thoracic spine gets smaller. So the total compression in that part of the spine is reduced. But the moment arm of the lumbar spine stays the same. You like stick your ass out. So your lumbar spine preserves the moment arm of the load. It doesn't change. What changes in the lumbar spine is the recruitment of the spinal extensors. Those things flex all hard so you don't fall down. And when they flex all hard like that, they squish your discs. So your lumbar compression goes way up in that posture. Same article. This is just the explanation of what they observed and some highlights from the discussion. Spinal flexion, right, meaning bending forward, doubles lumbar compressive forces, but doesn't increase the thoracic compression. The moment arm for the lumbar spine remains unchanged. You just shove your hips backward as the box moves in toward you. So the two variables at play are the moment arm of the load, right, spine to box, that distance, that varies, and then how much muscle activation there is in the spinal extensors. Those are the two variables that are influencing the compressive forces. Obviously, ignoring any vertical stacking of weight. I mean, if you put on a 50-pound hat, that's going to add compression to the entire vertebral column. Now, getting out of the back and looking into some other commonly injured areas, the shoulder is a really vulnerable joint. It's a multi-axial joint with an enormous range of motion, more than any other joint in the body, and that puts it at risk. And participating in a shoulder sport will elevate that risk. I mean, sport participation, just repetition of any movement pattern to excess, throwing a ball, swinging a racket, whatever, will change your mechanics. And jump mechanics are one domain in which we can see this phenomenon, one of many domains. And every sport has its own motor patterns and a sort of timing signature of execution. And we adapt specifically according to the loads and stresses we experience. This chart, you don't need to even make sense of it. You don't need to know anything about it, but it just represents how athletes jump, incorporating different force and time variables. And we're looking at volleyball, track, soccer, and handball. So if you take track, it's high force. They're all in the top half. Volleyball, similar. Handball and soccer, they're lower force. So we have different mechanics in different sport settings and experiencing overuse and overload through altered ranges of emotion, through altered mechanics, that can, in many cases, more than some cases, in lots of cases, it can predispose us to a higher risk of injury. So we get injured. Okay, something happens. You don't really need to know the slide at all. This is just population surveillance data from the Ministry of Manpower, MOM, from MOM. And where are we seeing injuries? Well, men more than women, ages 21 to 40 more often, uh, carrying stresses, awkward postures, lifting. It's a bunch of construction and manufacturing jobs and transport and storage. Maybe like sectum sempras on the little girl or whatever. Whatever it is, people get injured all the time, people are getting injured. You're in sport, you're doing whatever, and people are being injured in lots of ways. And so let's say it's a shoulder and it was an athlete. Again, very common site for injury. I mean, because the head of the humerus, it's not locked in place by ligaments and bone articulations. It's held in place by muscle attachments. The pecs and rotator cuff, and that's what's preventing displacement. And then you have stuff like the glenoid labrum for stability, but there's lots to injure in there. There's so much mobility, there's so much to injure, there's so much vulnerability in that joint. And then once it's injured, the muscle recruitment patterns get changed. The neural activation will be different. For the same exact task. So do a shoulder press, do a side raise, do a front raise. You'll recruit your muscles differently to accomplish those things. Most likely you will. So here you see changing muscle recruitment patterns in anterior shoulder instability patients compared to control. So there were 19 instability patients and 25 age-matched controls in this study. And you can see the picture. The subject's hand is on a switch, and she just raises her arm to touch a different switch. And so do that in the sagittal plane and do it in the frontal plane. And they collect EMG data on a bunch of different muscles. So in the top graph, that's the sagittal plane, looking at the supraspinatus, infraspinatus, teres major, posterior deltoid, upper trapezius, and the biceps. And you don't need to know the exact differences, which muscles fire differently. Just observe very generally that patients with shoulder instability compared to control populations recruit their muscles differently when performing the exact same task. And in the bottom graph, that's the frontal plane. It says coronal, right? That's the same thing as frontal. And that's the plane that the subjects are moving in for that one and tracking the EMG activity. And you can see in both planes that the biceps and the infraspinatus, they just go crazy in shoulder instability patients. You don't need to know any specific muscle pattern, just again, the concept that recruitment changes. And this is just one particular condition. Every injury is going to have a different reprogramming, a different signature of neural activation changes. And athleticism has a different reprogramming. Depending on your sport, each sport is going to reprogram in slightly different ways. Now, this is a study here looking at low back pain. Once you've experienced pain, and fear of pain and fear of re-injury, these things continue to influence how our muscles behave. The firing patterns of injured muscles or previously injured muscles produce weird EMG signals. So in the low back, some of it's bilateral, one side compared to the other, some of it's contribution from other body segments. But it's not just you deliberately avoiding painful things. We do that. People do that. We all avoid stuff that hurts as long as we don't have SEPA. We'll talk about that in the future. If we have functioning nociceptors, we avoid pain deliberately, consciously, we avoid pain. But even if you try to move normally, there's an involuntary, unconscious alteration in neuromotor characteristics. Concentrate as hard as you want on flexing correctly. It won't happen. It's not entirely under your control. And some of these differences aren't even normal voluntary recruitment. I mean, we're looking at reflex arcs, like muscle spindles being hijacked by pain. Now, this study here is a concept that I've mentioned before when we were talking about things that compromise skeletal muscle performance, like cold temperature and fatigue, static stretching and pain. Regarding pain, afferents affect efferents. I've said this earlier in the semester. Afferents affect efferents. Moving forward in this block, we'll talk all about peripheral versus central sensitization and hyperalgesia versus allodynia, concepts like this. But for now, just know that nerves release stuff, like substance P and CGRP, and that stuff can influence motor neuron excitability. So as we start to wrap things up, think about this. Neuromuscular recruitment patterns change after injury because of pain, because of fear of pain, because of fear of re-injury. The kinetics that produce your kinematics undergo change. And those altered firing patterns often predispose athletes to a higher risk of re-injury, an elevated risk of experiencing an additional injury. Now, when we're clearing athletes to return to play following injury, nobody's testing for this. Return to play testing batteries aren't testing anything neuromuscular. They're just testing gross movements. Can you exert force? Can you move through a full range of motion, without pain? What's your balance like? Things like this. If you pass that stuff, you're ready to return to play. They're not assessing whether the athlete is moving through that range of motion in a weird way. If anything kinetic has undergone change, that's not known, right? They're just looking at gross kinematics. So, where's the EMG data to see if the soccer player or softball player, swimmer has returned to a neural baseline? Oh, your infraspinatus is still firing really weird. Your crude force production is the same, but the kinetics are all wacky. So why don't we hold you out of practice for one more week? Just go do leg work for now, something like that. That's not a conversation we're having. We're not doing that. We're rushing athletes back onto the field or into the pool or on the diamond or court or whatever it is so that coaches can win, right? So that coaches get their contracts renewed or their salaries raised at the expense of a potential lifetime of pain and disability for the individual athlete who wasn't given sufficient time to heal correctly. So the process of healing is what we'll be talking about more and more as we move through this block. But for now, it's discussion time. So let me set the scene. Paul here, he gets injured, and it's a shoulder injury or something like that, and Coach Cutlip wants to get him back on the court. But we know that neuromotor alterations often occur following injury, generally occur following injury. And we know those altered patterns can predispose people to an elevated risk of re-injury. And we aren't testing these things in return to play batteries. They're just testing gross movements and range of motion and balance and quick and easy tests. That's what we're testing. And we're pretty bad at pain management. And we don't have an effective, reliable, standardized way of restoring neuromuscular function. So, what would you do? You're getting some foundational understanding of this stuff. First, what would you do with the return to play batteries? Would you change it at all? What would you keep? What would you ignore? What would you add? And what would you pay more or less attention to clear an athlete for participation? And then second, how would you fix neuromuscular recruitment? How would you fix that problem? What would you do to address it? And I realize like it's hard to discuss in a video format. So if you have ideas, leave a comment and that can be a format for us to talk through any ideas. But one idea I had, to get the discussion started was alcohol. Watch a drunk person walk, or get drunk yourself and walk and watch yourself. That is not an inhibited gait. It's all loose and uncaring. And so you're out of pain. It's an analgesic. Let's get you a little bit out of pain. And then let's get you uninhibited in how you're moving. The recruitment patterns are pretty much brand new. And so maybe that can help serve as a reboot button. And there's a ton more to talk about on that particular topic, but I'll leave it at that. Here are the review questions for this lecture. Especially pay attention to that diagram and how you would explain that one. And I will see you in the next lecture as we move more and more throughout this block into pain and injury and therapy.